I'm a neurosurgeon at Riverside Memorial Hospital in Portland, Oregon, or at least I was, until I submitted my resignation 6 weeks ago. You can call me Dr. Sarah Chen if you want, though most people in the surgical department just called me Chen during my 21 years there. What I'm about to tell you about is the one brain surgery that made me question everything I thought I knew about human consciousness, and ultimately led me to abandon neurosurgery entirely. For over 2 decades, I've dedicated my life to the most intricate and delicate surgeries the human body can demand. I've operated on brains, the 3-pound universe inside our skulls that somehow generates thought, memory, personality, and consciousness itself. I've removed tumors the size of golf balls from areas where a millimeter's mistake could erase a patient's ability to speak, to recognize their children's faces, or to remember their own name. I've performed emergency surgeries on car accident victims where their brain tissue was scattered like broken glass, somehow piecing together the fragments of someone's mind while racing against time and massive hemorrhaging. I've operated on aneurysms so delicate that touching them wrong would cause an instant, catastrophic stroke. I've removed brain tumors from regions that medical textbooks labeled inoperable, areas so critical to basic human function that most surgeons wouldn't dare approach them. Over my 21-year career at Riverside Memorial Hospital, I've performed more than 4,200 brain surgeries. That's roughly 200 operations per year, nearly 4 surgeries every single week for over 2 decades. I've saved lives that other neurosurgeons declared hopeless. I've given speech back to patients who were told they'd never talk again. I've restored movement to hands that specialists said would remain forever paralyzed. My surgical precision became legendary within the Pacific Northwest medical community. I was the neurosurgeon other neurosurgeons called when they encountered cases beyond their expertise. Residents from medical schools across the country requested rotations in my program. I've been published in the Journal of Neurosurgery 14 times, presented at international conferences in London, Tokyo, and Geneva, and consulted on cases as far away as Vancouver, San Francisco, and Anchorage. But there's one patient whose case files I still keep locked in my home office safe. One surgery that I've never written about, never presented at any conference, never discussed with colleagues, except in whispered conversations behind closed doors. One operation that revealed something so fundamentally impossible, so completely contradictory to every principle of neuroscience and brain surgery, that it shattered my confidence in everything I thought I knew about the human mind. The patient's name was Isabella Rodriguez. She was 28 years old, a graduate student in theoretical physics at Portland State University, working on her doctoral dissertation about quantum consciousness theories, an irony that still gives me chills when I think about it. What happened during her surgery on October 23, 2020, during the height of the COVID pandemic, was captured on our standard surgical recording equipment. The footage exists, multiple witnesses observed it, yet what we documented should be medically and scientifically impossible. What I'm about to tell you isn't just an unusual case or an unexplained medical outcome. It's evidence that our fundamental understanding of the relationship between the physical brain and human consciousness might be completely wrong, and that possibility that everything I'd learned in medical school, residency, and 2 decades of practice might be based on incomplete or incorrect assumptions about how consciousness actually works, terrified me so profoundly that I could no longer continue operating on human brains. Let me establish exactly who I was before Isabella Rodriguez's case destroyed everything I thought I knew about neurosurgery and consciousness itself. Riverside Memorial Hospital is one of the most prestigious medical centers on the West Coast. Our neurosurgery department handles the most complex brain cases from Oregon, Washington, Northern California, and Western Canada. We're the regional trauma center for head injuries, the referral destination for rare brain tumors, and the training ground for some of the most skilled neurosurgeons in North America. I joined Riverside fresh out of my fellowship at Johns Hopkins in 1999, when I was 32 years old, and absolutely convinced that I could master any challenge the human brain could present. Neurosurgery had always felt like the perfect intersection of my deepest interests: the precision and problem-solving of engineering, the life or death stakes of emergency medicine, and the profound mystery of consciousness itself. During my first year at Riverside, I focused primarily on standard tumor removals and trauma cases. But I quickly developed a reputation for my steady hands, my ability to remain calm during surgical crises, and my willingness to attempt procedures that other surgeons considered too risky. By my third year, I was regularly performing some of the most complex surgeries in the hospital. My specialty became awake craniotomies, brain surgeries, performed while the patient remains conscious and alert throughout the procedure. These operations are necessary when tumors or other abnormalities are located in critical areas of the brain responsible for language, movement, sensation, or other essential functions. By keeping the patient awake, we can continuously monitor their cognitive abilities while operating, ensuring that we remove the diseased tissue without damaging the healthy brain regions that make them who they are. Awake brain surgery requires an extraordinary level of skill, not just in surgical technique, but in patient management, communication, and real-time neurological assessment. You're literally talking to someone while their skull is open, and you're manipulating their brain tissue with surgical instruments. You might ask them to speak while you stimulate different areas of their language centers. You might have them move their fingers while you operate near their motor cortex. You might test their memory, their ability to recognize faces, or their capacity to solve simple math problems, all while performing microsurgery on the organ that generates these variabilities. I performed my first awake craniotomy in 2002, removing a tumor from a patient's left temporal lobe while she recited poetry to help us map her language areas. The surgery was successful. We removed 98% of the tumor while preserving all of her cognitive functions. But more than that, I was fascinated by the window this procedure offered into the relationship between brain and mind. Here was a woman whose consciousness remained fully intact, while I directly manipulated the physical organ that somehow generated her thoughts, memories, and sense of self. Over the following years, I became one of the leading practitioners of awake brain surgery in the Pacific Northwest. I developed new techniques for patient preparation and anesthesia management. I pioneered methods for real-time cognitive testing during surgery. I trained dozens of residents and fellows in these advanced procedures. By 2010, I was performing roughly 150 awake craniotomies per year, more than almost any neurosurgeon in the country. During these surgeries, I observed phenomena that constantly amazed me. Patients who could carry on complex conversations while I operated on their frontal lobes. Musicians who could play violin while I removed tumors from their motor areas. Artists who could draw detailed sketches while I worked near their visual processing centers. Each case reinforced my understanding of how different brain regions control different aspects of human experience and ability. I thought I had seen everything the conscious brain could do during surgery. Patients who remained remarkably calm and composed despite having their skulls opened. People who could perform incredible cognitive feats while under extreme stress. Individuals whose personalities seemed to shine through, even in the surreal environment of the operating room. But I had never witnessed anything that fundamentally challenged the basic principles of neuroscience. Everything I observed could be explained by our established understanding of brain anatomy, neural networks, and the relationship between specific brain regions and particular cognitive functions. Even the most remarkable cases fit within the framework of what medical science told us was possible. My confidence in neurosurgery grew stronger with each successful operation. By 2015, I was regularly consulted on cases that other surgeons deemed inoperable. Medical centers across the region would transfer their most challenging patients to my service. I had developed a reputation not just for technical skill, but for my willingness to attempt surgeries that pushed the boundaries of what was considered medically feasible. I published papers on advanced surgical techniques, presented at international conferences about consciousness and brain surgery, and served on editorial boards for major neurosurgical journals. I was invited to give lectures at medical schools, consulted on legal cases involving brain injuries, and interviewed by medical journalists writing about breakthrough surgical procedures. By 2020, I felt like I had achieved mastery over my field. I could navigate the most complex brain anatomy with confidence. I could predict with remarkable accuracy how different surgical approaches would affect cognitive function. I understood the intricate relationships between brain structure and mental experience. I had performed thousands of surgeries with consistently excellent outcomes. Most importantly, I had never encountered anything that couldn't be explained by established neuroscience. Every patient's response to surgery, every unexpected outcome, every remarkable recovery could be understood through our existing knowledge of brain function, neuroplasticity, and the relationship between mind and brain. I believed that consciousness was fundamentally a product of brain activity, that our thoughts, memories, personalities, and sense of self emerged from the electrochemical processes occurring within our neural networks. This wasn't just my professional opinion, it was the foundation upon which my entire career was built. Every surgery I performed was based on the assumption that by manipulating specific brain regions, we could predictably affect corresponding aspects of mental function. This confidence, this certainty about the nature of consciousness and brain function, made me one of the most sought-after neurosurgeons in the Pacific Northwest. Patients and families trusted me to operate on the most precious and mysterious organ in the human body because I projected absolute confidence in my understanding of how that organ worked. But Isabella Rodriguez's case shattered that confidence completely. What happened during her surgery didn't just challenge my surgical skills or present an unusual medical outcome. It revealed something about consciousness, about the relationship between mind and brain, that contradicted everything I had learned in medical school, residency, and 2 decades of practice. Something that suggested our entire scientific framework for understanding human consciousness might be fundamentally incomplete or even wrong. And once you've witnessed something that challenges the very foundations of your expertise, once you've seen evidence that everything you thought you knew might be incorrect, you can never approach your profession with the same certainty again. This is the story of Isabella Rodriguez and the brain surgery that ended my 21-year career as a neurosurgeon. But before I tell you what happened in that operating room on October 23, 2020, you need to understand something crucial. I am not alone. In the weeks following Isabella's surgery, after word began to spread quietly through the neurosurgical community about what we had witnessed, 5 other neurosurgeons contacted me privately. They shared similar cases, operations where they had observed phenomena that contradicted established neuroscience, experiences they had never reported or discussed publicly because they feared it would destroy their credibility. We're not talking about unexplained recoveries or miraculous healing. We're talking about conscious human minds demonstrating capabilities during brain surgery that our entire understanding of neuroscience says cannot exist. We're talking about evidence that consciousness might not be as dependent on the physical brain as we've always assumed. We're talking about observations that suggest the relationship between mind and brain might be far more complex and mysterious than our medical textbooks claim. And once you've seen it happen, once you've witnessed a patient's consciousness do something that should be neurologically impossible while their brain is exposed and you're operating on it, everything changes. Every assumption you've built your career on becomes questionable. Every confident statement you've made about brain function becomes suspect. Every surgery you perform afterward carries the weight of knowing that you might not understand consciousness as well as you thought you did. That's why I resigned from Riverside Memorial Hospital. That's why I can no longer practice neurosurgery. That's why Isabella Rodriguez's case still haunts me, months after I walked away from the operating room for the final time. Because once you've seen the impossible happen during brain surgery, you realize that maybe, just maybe, We don't understand the human mind nearly as well as we pretend to do. I'm a neurosurgeon at Riverside Memorial Hospital in Portland, Oregon. Or at least I was until I submitted my resignation 6 weeks ago. You can call me Dr. Sarah Chen if you want, though most people in the surgical department just called me Chen during my 21 years there. What I'm about to tell you about is the one brain surgery that made me question everything I thought I knew about human consciousness, and ultimately led me to abandon neurosurgery entirely. Riverside Memorial Hospital wasn't just another medical center, it was a cathedral of modern medicine, a place where the impossible became routine and miracles were measured in millimeters. The neurosurgery department occupied the entire 7th floor of the main building, a sprawling complex of operating theaters, recovery units, and specialized equipment that represented the cutting edge of brain surgery technology. Walking through those corridors every morning for 21 years, I felt like I was entering a different world. The sterile white walls were lined with brain scans, CT images, MRIs, PET scans, illuminated on viewing boxes that revealed the intricate architecture of human consciousness rendered in grayscale shadows and bright contrasts. Each image told a story of damage and possibility, of tumors to be removed and lives to be saved. Our department handled cases that smaller hospitals couldn't even dream of attempting. We were the final destination for patients whose conditions were deemed inoperable, the last hope for families who had been told there was nothing more that could be done. Brain tumors in locations that textbooks called eloquent areas, regions so critical to speech, movement, memory, or personality that most surgeons wouldn't risk operating on them. Arteriovenous malformations twisted like deadly spider webs through the brain's blood supply, aneurysms ready to burst and cause catastrophic strokes, traumatic injuries where fragments of skull had been driven deep into brain tissue. The operating theaters themselves were technological marvels. OR7, where I performed most of my surgeries, was equipped with a surgical microscope that could magnify brain tissue up to 40 times normal size. The walls were lined with monitors displaying real-time brain imaging, vital signs, and neurological monitoring data. We had intraoperative MRI capabilities that allowed us to take detailed brain scans without moving the patient from the operating table, ultrasound equipment that could map blood vessels in real time, electrical stimulation devices that could test brain function while we operated. But the most sophisticated technology in that operating room was the team of people who made these miracle surgeries possible. My surgical team had worked with me for over a decade, and we moved together with the precision of a Swiss watch. Rebecca Martinez, my lead surgical technician, could anticipate which instrument I needed before I asked for it. Dr. James Wong, my anesthesiologist, had perfected the delicate art of keeping patients conscious during brain surgery while managing their pain and anxiety. Patricia Thompson, our neuropsychologist, could conduct real-time cognitive assessments while I operated on a patient's exposed brain. The scope of our work was staggering. Our department performed over 800 brain surgeries per year, ranging from routine tumor removals to experimental procedures that pushed the boundaries of what was medically possible. We operated on infants with birth defects that affected brain development, children with rare genetic conditions that caused devastating seizures, teenagers injured in car accidents or sports injuries, adults with brain cancer, and elderly patients with conditions that threatened their cognitive function. Each case required not just surgical skill, but the ability to navigate complex ethical and emotional terrain. Brain surgery wasn't like operating on a kidney or removing a gallbladder. We were working on the organ that generated everything that made our patients who they were. A mistake during a routine appendectomy might cause infection or scarring. A mistake during brain surgery could erase someone's ability to speak, recognize their spouse, or remember their children's names. The families we dealt with were often desperate, having been told by multiple doctors that their loved one's condition was hopeless. They came to us carrying years of medical opinions, stacks of brain scans from other hospitals, and the kind of hope that only emerges when all other options have been exhausted. I spent countless hours in consultation rooms, explaining complex surgical procedures to people who were trying to understand how we could possibly operate on their father's brain tumor, their daughter's arteriovenous malformation, or their spouse's aneurysm. These conversations required a delicate balance between honesty and hope. I had to explain the very real risks: permanent paralysis, loss of speech, memory problems, personality changes, or death, while also conveying my confidence in the surgical plan and the possibility of successful outcomes. I had to help families understand that brain surgery was never routine, that every operation carried risks that could fundamentally alter their loved one's life, but that without surgery, the alternative was often certain death or progressive deterioration. My reputation within the hospital extended far beyond technical surgical skill. I was known for my ability to communicate with patients and families during the most terrifying moments of their lives. I could explain complex neurological concepts in language that non-medical people could understand. I could project calm and confidence even when discussing surgeries that carried significant risks. Most importantly, I could help people make informed decisions about procedures that would affect the rest of their lives. The complexity of our work required constant collaboration with specialists from across the medical spectrum: neuro-oncologists who understood the biology of brain cancers, radiation oncologists who could design treatment plans to target residual tumor cells after surgery, neurologists who specialized in seizure disorders, movement problems, and cognitive dysfunction, psychiatrists who helped patients and families cope with the psychological impact of brain surgery, social workers who coordinated care plans and connected families with support resources. Our weekly tumor board meetings brought together 15-20 specialists to review complex cases and develop comprehensive treatment plans. These sessions were intellectually challenging discussions where we analyzed brain imaging studies, reviewed pathology reports, and debated treatment options for patients with conditions that pushed the boundaries of medical knowledge. The decisions we made in these meetings directly affected whether patients lived or died, whether they maintained their cognitive abilities, and what quality of life they could expect after treatment. The educational aspect of our program was equally demanding. As a teaching hospital affiliated with Oregon Health and Science University, we trained medical students, residents, and fellows who came from around the world to learn advanced neurosurgical techniques. The residents in our program were among the brightest minds in medicine, having competed successfully for positions in one of the most selective specialties in healthcare. Training neurosurgeons requires a unique combination of technical instruction, gradual responsibility increase, and philosophical education about the profound implications of operating on the human brain. I taught residents not just how to perform specific procedures, but how to think about each patient as a unique individual whose brain had its own distinctive anatomy, pathology, and functional organization. Every brain is different, I would tell new residents during their first week in our program. You can study anatomical textbooks and memorize standard surgical approaches, but when you open a patient's skull, you're encountering a unique organ that has been shaped by genetics, experience, injury, and disease in ways that make it unlike any other brain you've ever seen. This philosophy extended to our approach to consciousness and cognitive function. While we could predict with reasonable accuracy how damage to specific brain regions would affect certain abilities, the relationship between brain structure and mental function was far more complex and mysterious than medical textbooks suggested. I taught residents to approach each surgery with both confidence in their technical skills and humility about the profound mysteries of consciousness that we were manipulating. The international recognition our program received led to consulting opportunities and collaborative relationships with neurosurgical centers around the world. I regularly reviewed cases for hospitals in Vancouver, Seattle, San Francisco, and Denver. Medical centers in Europe and Asia sought my opinion on complex surgical approaches or invited me to perform particularly challenging procedures. These collaborations exposed me to different surgical techniques and philosophical approaches to neurosurgery that constantly expanded my knowledge and perspective. My research interests focused on the relationship between brain structure and cognitive function, particularly in the context of awake brain surgery. I had published 47 peer-reviewed papers on topics ranging from surgical techniques for preserving language function to methods for real-time cognitive assessment during brain tumor removal. This research was cited by neurosurgeons and neuroscientists worldwide and helped establish protocols that were now used in major medical centers across North America and Europe. The speaking engagements that resulted from this research took me to conferences and universities around the globe. I delivered lectures in London about preserving cognitive function during eloquent area surgery, presented in Tokyo about anesthetic protocols for awake craniotomy procedures, and participated in panel discussions in Geneva about the ethics of experimental neurosurgical techniques. But perhaps the most rewarding aspect of my career was the direct impact on individual patients and families. Over 2 decades, I had the privilege of removing brain tumors that would have killed patients within months, allowing them to return to their careers, families, and normal lives. I repaired aneurysms that could have caused fatal strokes, giving people decades of healthy life they wouldn't have had otherwise. I operated on traumatic brain injuries that restored function that other doctors had declared permanently lost. The success stories accumulated over the years. A concert pianist whose brain tumor was located in the motor cortex controlling her right hand, and who played Chopin during surgery to help me preserve her musical abilities. A professor of linguistics with a tumor in his language areas who discussed etymology and syntax while I operated on his speech centers. A professional athlete whose skull fracture had damaged his motor cortex, and who regained enough function to return to competitive sports. But the cases weren't just about successful outcomes. They were about the profound privilege of working at the intersection of medicine, neuroscience, and human consciousness. Every surgery provided a unique window into how the 3-pound organ inside our skulls somehow generates the rich inner life that makes each person who they are. The letters and cards I received from patients and their families filled several boxes in my office. Photos of children who had grown up healthy after brain tumor surgery in infancy. Wedding invitations from patients who had been told they might not live to see their next birthday. Christmas cards from families whose lives had been transformed by successful surgery. Graduate school announcements from young adults who had overcome childhood brain injuries to achieve academic success. These personal connections reminded me why I had chosen neurosurgery in the first place, the opportunity to directly impact human lives in the most profound and meaningful way possible. But they also reinforced my sense of responsibility and the weight of the decisions I made every day. When you operate on someone's brain, you're not just treating a medical condition, you're potentially altering everything that makes that person who they are. The technical demands of neurosurgery required constant learning and adaptation. New imaging techniques provided better visualization of brain anatomy and pathology. Advanced surgical instruments allowed for more precise tissue manipulation. Improved understanding of brain function led to better strategies for preserving cognitive abilities during surgery. I attended multiple conferences each year, completed continuing education requirements, and constantly updated my knowledge base to incorporate the latest advances in the field. The psychological demands were equally challenging. Every surgery carried the risk of catastrophic complications that could leave a patient permanently disabled or dead. The decision-making process for complex cases involved weighing risks and benefits that affected fundamental aspects of human existence: speech, memory, personality, and consciousness itself. The pressure to achieve perfect outcomes while operating on the most complex organ in the human body was constant and intense. By 2020, I had achieved everything I had dreamed of when I first decided to become a neurosurgeon. I was recognized as one of the leading practitioners in my field, with a reputation for taking on the most challenging cases and achieving excellent outcomes. My surgical techniques were being taught in medical schools, my research was advancing the field of neurosurgery, and my training program was producing the next generation of skilled brain surgeons. I had developed a systematic approach to every aspect of brain surgery, from patient selection and preoperative planning to surgical technique and post-operative care. I could look at brain scans and immediately identify the optimal surgical approach. I could predict with remarkable accuracy how different surgical strategies would affect cognitive function. I could perform the most complex procedures with steady hands and calm confidence, even when operating in areas of the brain where millimeter mistakes could have devastating consequences. Most importantly, I had never encountered a case that fundamentally challenged my understanding of brain function and consciousness. Everything I observed during thousands of surgeries fit within the established framework of neuroscience. Patients' responses to surgery, their cognitive abilities during awake procedures, and their recovery patterns all aligned with what medical textbooks taught about the relationship between brain structure and mental function. This consistency reinforced my confidence in the scientific principles underlying neurosurgery. I believed that consciousness was fundamentally a product of brain activity, that our thoughts and personalities emerged from the complex interactions of neural networks, and that by understanding brain anatomy and function, we could predict and control the effects of surgical intervention. This worldview wasn't just my personal opinion, it was the foundation of modern neurosurgery. Every procedure we performed, every surgical decision we made, every prediction we offered to families was based on the assumption that mind and brain were intimately connected, that consciousness depended on the physical integrity of neural tissue, and that surgical manipulation of the brain could predictably affect mental function. The professional environment at Riverside Memorial fostered this confidence through its emphasis on evidence-based medicine, rigorous scientific methodology, and continuous quality improvement. Our surgical outcomes were tracked, analyzed, and compared to national benchmarks. Complications were reviewed in detail to identify opportunities for improvement. New techniques were carefully evaluated before being incorporated into clinical practice. This systematic approach to neurosurgery created an atmosphere of controlled precision, where every aspect of patient care was optimized for successful outcomes. We had protocols for preoperative preparation, standardized surgical techniques, and comprehensive post-operative monitoring. The combination of advanced technology, experienced personnel, and evidence-based practices made our neurosurgical program one of the most successful in the region. But all of this confidence, all of this systematic precision, all of these evidence-based protocols were built on fundamental assumptions about consciousness and brain function that I had never had reason to question, until Isabella Rodriguez's case revealed something that challenged not just my surgical expertise, but the basic scientific framework that had guided my entire career. What happened during Isabella's surgery on October 23, 2020, wasn't just an unusual outcome or an unexpected complication. It was evidence that our understanding of the relationship between brain and consciousness might be fundamentally incomplete. And once you've seen something that challenges the basic assumptions of your field, everything changes. Every surgery becomes a question rather than a routine procedure. Every confident statement about brain function becomes suspect. Every interaction with patients and families carries the weight of knowing that you might not understand consciousness as well as you thought you did. That's why I resigned from Riverside Memorial Hospital. That's why I can no longer practice neurosurgery. That's why Isabella Rodriguez's case still haunts me, months after I walked away from the operating room for the final time. Because once you've seen the impossible happen during brain surgery, once you've witnessed something that contradicts everything you thought you knew about consciousness, you realize that maybe, just maybe, we don't understand the human mind nearly as well as we pretend to do.